So I have the privilege of introducing our speaker tonight. Dr. Laura Roettger is an assistant professor and director of the Pediatric Nurse Practitioner Program in the College of Nursing at Jefferson, Philadelphia University, and Thomas Jefferson University in Philadelphia, Pennsylvania. She serves as chair of the Childhood Obesity Special Interest Group for the National Association of Pediatric Nurse Practitioners. She has provided care for pediatric patients and their families for more than 14 years in both the pediatric hospital and outpatient settings. Her research interests focus on childhood obesity, adverse childhood experiences, and simulation pedagogy, in graduate nurse practitioner education. Her education includes a Bachelor's of Science in Nursing, Master's of Science in Advanced Practice Nursing from Thomas Jefferson University, and a PhD in nursing philosophy from the Catholic University of America. And thank you so much, Laura, for being here today with us.
Thank you, Chaka, and thank you, Michelle, for the great introduction. I'm delighted to be with all of you today and to share with you a topic that I unfortunately see day in and day out in my clinical practice. So let me share my screen with you and I'll bring up my presentation. Okay, so again, the topic is going to cover childhood food insecurity, the trends and implications for practice and policy. I have no conflicts of interest to proclaim. And the objectives of the presentation will be to describe the prevalence, influencing factors, and causes of food insecurity in the United States, discuss the impact of food insecurity on child health, discuss the implications of food insecurity on the role of the advanced practice nurse, and explain the influence of policy on food insecurity. So let's just first begin with the definition of food insecure, so we're all on the same page. It is the insufficient or inconsistent access to food as a consequence of low financial means or social influences. And it further breaks down into measures of low food security and very low food security. Low food security being low diet quality, variety, or desirability, resulting in a small or no reduction in food consumption. And very low food security, which is defined as several indications of disordered eating patterns and a reduction in food consumption. And food insecurity, unfortunately, correlates with poor health, social, and academic outcomes in children, which we'll get into in the upcoming slides. So let's first start off with the numbers. So in terms of statistics in the United States and utilizing data from the USDA's food security statistics, which are based on a national food security survey conducted as an annual supplement to the monthly current population survey put out by the Bureau of the Census for Labor Statistics, we get data on food security. And these questions are geared towards food spending, again, food security in the household, the use of federal and community food assistance programs. And what the numbers tell us for the United States is that the United States households with children under the age of 18 years old, 13.6% of households, about 35 million children, were food insecure in 2019. This compares to the national average of 10.5%. And in some households, food insecurity affects only the adults, as parents will feed their children prior to themselves. In 6.5% of households that are food insecure, both adults and children were food insecure. And then in about 0.6% of food insecure households, children experienced very low food security. If you can recall, this equates to disordered eating patterns and limited food consumption, which is a very serious concern related to food insecurity. And what the report also highlights is that there are certain household characteristics which were attributed with higher rates of food insecurity. Those with children in general, those with children under the age of 6 years old, households with single parents, those in households that are of Black, non-Hispanic, or Hispanic households. Looking at income levels, households with incomes 185% below the poverty threshold. This indicates that our social environments have a relationship on food insecurity, and that those affected to a greater degree are those communities that are economically and socially challenged. And which we'll get into in terms of our action as advanced practice nurses, what we can do at different levels of policy. But this is the statistics for looking at food insecure households experiencing disruptions in food security during 7 months of the year. This next slide indicates those characteristics associated with very low food secure households experiencing disruptions in food security during 7 months of the year. Again, highlighting in those same household characteristics. Those with children had a higher degree, those single parent households, those in Black, non-Hispanic, and Hispanic households had a higher prevalence rate, as well as those in lower income households. The good news is that prevalence rates of food insecurity have shown a steady decline over the past 8 years. So in 2011, the rate was 14.99%, and in 2019, we've gone down to 10.5%. And the prevalence of very low food insecurity has also shown a steady decline over the past 8 years, 5.7% in 2011 to 4.1% in 2019. But what about its impact on child health? Because that most of us, clinically focused, research-driven, policy facing, what does this mean for the effects on child's medical and well-being? Well, the data indicates that behavioral health is affected. We'll see developmental delays in these children, depression, anxiety, leading to suicidality in adolescence, toxic stress, obesity, malnutrition, dental caries, and iron deficiency anemia. So in the clinical setting, we must be alert of this impact so that we can be aware of what to look for, what to screen for. In terms of behavioral health, particularly in the younger age group, studies have indicated that those children in kindergarten who were food insecure showed reduced academic achievement in both math and reading over a 4-year period. So again, do these kids have after-school programs that are supported in the community? Or is this a conversation that needs to occur between the healthcare provider and the parent? Or is this something that the practice, that the healthcare providers in the practice can be proponents of supporting after-school programs in communities that are greatly affected? So I tie in here also the impact of the COVID pandemic. And there was a survey put out by the Census Bureau that measured food insufficiency with one question. And so you'll note the difference. I note food insufficiency here, which can have denote a different meaning than food insecurity. However, the measure that was utilized in the survey correlated well with the food insecurity measure. And so through these this analytical process that they went through, it was a good correlate to food insecurity. And the question that was asked in the last 7 days, which of these statements best describes the food eaten in your household? And they would answer either enough of the kinds of foods we wanted to eat, enough, but not always the kinds of food we wanted to eat, sometimes not enough to eat, and often not enough to eat. And responses of 3 or 4 are classified as food insufficient. So oftentimes and sometimes the survey responses indicated that they did not have enough to eat. 9.5% of households were food insufficient during the months of April 25th through May 5th of 2020, during that survey period. And 9.6% of households that were surveyed were insufficient during the month of October 2020. So again, this was a supplemental survey that went out to communities to identify food insecurity. Again, they measured this with food insufficiency, but it has been shown to be a strong correlate to the food insecurity measure that is measured in that previous survey that I had referenced earlier in the presentation. So what can be done at the clinical level, research level, policy level? So we've identified that there are certainly effects on health in part due to our social and physical resources. The support in our homes, our neighborhoods, our communities, our schools, they all influence our health. And so that's where we need to target our actions. And ask those questions of our patients. Are you able to get to the food store? Do they have a car? Oftentimes, these communities that have been affected are in lower socioeconomic areas, in which case families do not access a car, so they can't get to a grocery store a mile away. Could they walk? Maybe, but it might not be safe. And oftentimes these neighborhoods also coexist in food deserts. And food deserts are those areas that are lacking or limited in nutritional food sources. So lack of full service grocery stores. They have to rely on a corner grocery store that might have higher prices, limited quality, limited availability of healthful foods. And then they may then choose the non-healthful foods. Presence of fast food restaurants are oftentimes in these neighborhoods as well. Lack of cultivatable land is also another challenge in these areas. Climate change has been another issue that is affecting food security in these communities. Globally, the additive effects of changes in rainfall, severe weather events, increasing infiltration of weeds and pests on crop plants is detrimental to the production of crops. And so we're seeing a decline in crop production. Additionally, livestock and fish production is expected to decline. This is predicted to be compounded with the increased price of petroleum used for pesticides and fertilizers. And with this decrease in production and increased petroleum cost, a resultant price hike will occur at the consumer level. And so these families who are already disadvantaged financially and in their environment, they have lower access to nutritious foods, well, they're going to be further impacted. With the price increase, again, food insecurity increases, and they won't be able to compensate with, they will compensate with poor nutrient-rich foods, high-calorie foods that can lead to those issues that were presented previously in terms of malnutrition and obesity. So I just want to share with you a short video. I think a lot of our nature as pediatric providers is driven by the human lives in which we have touched and gives us the passion to go on to serve others. I think this video gives us that human story, giving us a window into the communities that have been affected by food insecurity. It addresses some misconceptions, gives us some realistic perspective that we can utilize as practitioners to act upon. So let me see.
As a mom, I want to be able to give my children the things that they need, and one of the primary responsibilities of a mom is to feed her kids, and that is hard to do on a budget. The things that are less expensive are the things that are less healthy. I want to be able to buy the produce and the dairy that's fresh and healthy. I want them to be able to have the energy that they need to run around and play. My name is Brittany. My husband is Clint. We have 2 little boys, and we love spending time together. Things were really tight, and one of our neighbors mentioned the Utah Food Bank brought food to our neighborhood, and there was a whole truckload of food. I was really excited and humbled someone would be willing to donate all of that sort of thing and that we could have that. When we say that we're homeowners, people think that we have it made, that we don't struggle with money, but we do. Bills are really tight. We still have to make those choices and live on a budget. I use coupons. I do babysitting for the neighbors during the day, and I work at night. My husband has a college degree, and yet our income is still in the poverty level. Last year, we didn't turn the heat on during the winter. We had a little space heater that we used, and we all slept in the same bedroom. It's a terrible feeling as a mom, but it's a reality. Do you get the medicine? Do you get the fresh food? Do you get the pair of shoes, or do you send them to school in November with sandals? I couldn't possibly tell you the difference it has made in our lives, that I have felt like a better mother, that I've been able to provide more for my children. The money that we were able to save on our groceries has helped us to be able to get back on our feet.
Okay. So again, I think that brings to life all the complicated issues, the factors that really play into our role as clinicians, again, researchers, policy drivers. It drives our action. We don't want our families to have to choose between going out to buy food to eat or getting new school sneakers for the new school year. So again, I think that brings the realness to this topic. And let's see. Oh, there we go. Okay. So in terms of action, what can we do? Well, at the practice level, we can assess for vulnerabilities to identify places, communities at risk for adverse health outcomes, develop and implement an action plan. Again, the practice level, we could then step it up to the community level and then go to our state level, federal level. At a practice level, we can screen using the Hunger Vital Sign, which is a survey measure that is supported by the American Academy of Pediatrics. It was developed by Child's Health Watch, and it's 2 questions. Parents respond on a 4-point Likert scale from often true to they're not sure. Questions are, within the past 12 months, were you worried about whether food would run out before you got money to buy more? And the second question is, within the past 12 months, was the food you brought, did it last? And were you worried that it wouldn't last and you wouldn't have money to buy more? So just 2 simple questions that can be asked at a visit. At a community level, what are some of the things that as practitioners can we get involved in? Can we support? Well, in terms of community food production resources, we can support community gardens, the development of these places for families to go and obtain affordable food. Can these also be in areas that are more accessible by families? We know these children are going to school. Can these be based in the school setting to make it a little bit easier for them to access? We can support community-supported agriculture. In my practice, we have collaborated with farmers in the area that will deliver fresh produce to our patients who are really struggling to get that on the table. And also those populations that are highly at risk, specifically those with diabetes, are really that targeted population we're looking at specifically in my practice. But can we formulate a collaboration between the CSAs? And if you're not familiar with CSAs, these are partnerships between a farm and a community of supporters that provides the farmer with the monetary support to continue to grow their farm, as well as give families healthy food, fruits and vegetables on their table. Availability and affordability of food retail stores. So again, are these food deserts an issue in our communities? And how can we strategize with families to help them, assist them in getting healthy food? At a state level, SNAP and WIC are offered. SNAP is a supplemental nutrition assistance program. It is state regulated. It's dependent on income level in relationship to the federal poverty level. And oftentimes, to increase awareness of SNAP, the SNAP will engage with community partners like a food bank, and they welcome collaborations with community partners like food pantries, senior centers, libraries, schools, other community events, healthcare practices. Perhaps could you, sponsor a table for a SNAP representative to come into your practice periodically to screen and to interview families who may be interested. WIC is a supplemental nutrition program for women, infants, and children. It's state regulated, again, dependent on income level in relationship to the federal poverty level, which providing wholesome food, nutrition, education, community support for income eligible women who are pregnant and postpartum infants and children up to 5 years of age. So the Child Nutrition Act, the goal of this act is to strengthen and expand food service programs for children. It authorizes programs such as the school lunch program, school breakfast, summer food service, and child and adult food programs, as well as WIC and SNAP. Many child nutrition programs are permanently authorized and have permanent authorizations of appropriations, in which case they have no expiration date. This is the case with the National School Lunch Program, Special Breakfast Program, Child and Adult Care Food Program, and Special Milk Program, as well as the Summer Food Service Program. FFVP, or Fresh Fruit and Vegetable Program, provides funding for fresh fruit and vegetable snacks in elementary schools with priority for low-income schools. And I skipped over the WIC Farmers Market Nutrition Program, provides vouchers for WIC participants to redeem at farmers markets. So there you see that collaborative between the community and policymakers in terms of helping these communities to access healthy foods. The Healthy Hunger-Free Kids Act supports child and adult care food programs to offer dinners in all 50 states. Also allows for free lunch and breakfast programs for children in high poverty areas. These are my references. I thank you for your kind attention, and I'll turn it back over to Michelle and Cheka.
Thank you so much. I really appreciated your presentation, and thank you for being here today. It was a lot of information that I'm not familiar with, and I have a question regarding, I know you do some research in adverse childhood experiences, and I was just wondering if you've seen a correlation among food insecurity and ACEs.
Yes, so there's definitely an increase in toxic stress levels in a household that is really struggling to get food on the table. And so these children, and there has been research that has correlated the two in terms of worsening toxic stress, and maybe, you know, households that already have some other disruptive patterns as it is. And on top of it, the food insecurity certainly compounds the issue.
Thank you. I would like to open it up for any additional questions from anyone else on the call.
Hey, thank you so much, Laura, for your presentation. A question I had is, you know, particularly around the part of climate change and also the food, you know, like the ways that in which you suggested potentially people could do some advocacy work. I know that you mentioned the community supported agriculture. Are there any legislative kinds of efforts or things that you're aware of that, you know, think about climate change? And I mean, and look at the impact on obesity and the, fact that people may be more prone to living in these food deserts because of some of these implications for it.
Yeah, Sarah, it's interesting that you asked that question because that was actually something new I learned in putting this presentation together. I was also intrigued myself. I'm not familiar with any legislature, but it certainly highlights an area of, further investigation in terms of, what can be done at a series of levels in terms of, that being a big part of providing healthful foods and where some of our programs are being, funneled from, as was highlighted. So it could really be, a major concern, as we look ahead.
Thank you so much.
Mm-hmm.
Are there any other questions while we have Laura here with us? Okay, again, Laura, I thank you so much for your time, for joining us tonight and giving us this education on what we can do as our part in looking at screening and advocating. So I really appreciate your time.